As most of you know, I recently got this job as Medical Director of Quality Improvement. But that's a pretty vague title, so I'd like to start out by defining what I think the goals of this job are, and then talk about some of the barriers to these goals. Lastly, I'm going to finish by proposing some solutions to overcoming these barriers. I think our primary goal is to improve patient care. I think we can all agree on that. That's what we do. But that turns out to be a metric that's a bit tough to gauge, especially if you want to monitor your progress over time. It's just difficult to measure. So you could just ask the patient what he thought of his experience, but that too is a bit onerous with surveys and interpretation and qualitative analysis. Fortunately, PIA is highly correlated with patient experience. In fact, it's the most highly correlated variable we record, as well as patient outcomes. Patients who wait longer to see a doctor tend to die more frequently. It's also very easily measured. And ED-LOS is also important. So these are useful stand-ins for quality of patient care. And as a fortuitous corollary, I think we can also improve our experience in the ED by improving the patient's experience. Basically, when my patients are happy, I'm happy. My methods for this presentation were pretty simple. I got data from January 1st to May the 5th, 2015 from Meditech, and then had them checked by Tammy Vaudry for accuracy. Then I ran queries on them. Much of my talk will be based on these data. So if we're going to improve our PIA and ED-LOS, then we need to ask ourselves what affects these two variables. Well, the first variable that comes to mind is volume. That is, if we have a high volume of patients coming into the ER, one would expect that those patients would wait longer to be seen. This is true, but only to a certain extent. You can see the R-squared value of 0.1, meaning that only 10% of the variability in PIA is accounted for by the number of people who come in on that day. For ED-LOS, the effect is minimal. That is, how long a patient stays in our ED is not determined by how many patients visit on that day. Inpatients, on the other hand, do have a large negative impact on both PIA and ED-LOS, which you can see here. The R-squared values are a little less than 22 and 33 respectively, and this is only accounting for one moment during the day at 0700, so the correlation might be even stronger if we averaged it throughout the day. The speed of doctors who are working on that day also affects how long patients wait to be seen and how long they spend in the department. Importantly, the significance of this effect is as big as the number of inpatients in the department for PIA and is fairly large for ED-LOS as well. So I've explored three variables, and there are many more that we could examine, but I think we need to focus our efforts to what we know has an effect and what we know we can change. With regards to volumes, we know these are going up. We've all seen those data, but this is a good thing. These people are our clientele, and we want to remain in business, so we neither can nor should attempt to discourage increasing volumes. Inpatients, on the other hand, do have a large negative impact on our times, and these patients would be better served elsewhere in the hospital. Unfortunately, this isn't directly under our control, but I think we can and should pressure the administration to lighten this burden for us. Lastly, doctor speed is one variable that is solely under our control, so I'm going to focus the majority of my talk on this. I'm going to discuss 5 strategies to improve our performance. A strategy for inpatients, an improved schedule, MD efficiency, patient complexity, and playing the waiting times game. Firstly, inpatients. The purpose of an inpatient strategy is to make us faster by giving us space to work. So we can ask ourselves, how is the administration done at decreasing the inpatient burden on the ED over time? And the answer is not very well. You can see a slight, if any, downward trend over the past 3 years from 16 to 15 inpatients. But over the long term, say looking at data from a decade ago when there were 6 to 10 inpatients on average, this problem has actually become a lot worse. So I believe that this indicates that we need to change our approach with the administration. Firstly, I think we need to appeal to reason. They need to see the graphs I just showed you. and they need to be told that our numbers and our care suffer as a result of inpatient boarding in the ED. Secondly, we need to appeal to fairness. I know of no other department that has examined, or even would examine, patients in hallways, utility alcoves, or bathrooms, as we have done. I've spoken with the fire marshal, and he tells me that there's no difference between the ER and the rest of the hospital. There's no law that says that we can have patients in our hallways while the rest of the hospital can't. It isn't fair that we bend over backwards to accommodate them. And I think the administration needs to hear this message repeatedly. On one day that was particularly egregious, I had a single room in Blue Zone between me and my resident to see all of our patients, so I phoned up Mr. McNeil to express my frustration. I got his answering machine, so I phoned Grace St. Jean, who was almost as empathetic as David McNeil's answering machine. But I'm easy to ignore if it's just me. If multiple people are phoning with relative frequency, it becomes harder to ignore. And we can multiply our voice by adding other voices to it. I'm thinking particularly of patients and their families, as well as organizations. I mentioned the fire marshal, and CAPE has a statement on inpatient boarding in the ED, so perhaps we can bring their opinions in to support us. Up to this point, the strategy I've advocated for is largely based on cajoling and coddling the administration to act in the best interest of our patients. But as I've shown, this might be a long time coming. So in the meantime, I think we should take charge and change what we can, and I'm really referring here to stretchers. Where possible, I think these should be replaced by examination tables. We all want to be accommodating, so we'd like the 80-year-old lady with abdominal pain to have a place to lie down. Unfortunately, as I've just shown, the more accommodating we are in this regard, the less accommodating we are being of other patients. The 80-year-old lady in a bed means that another patient is sitting in the waiting room without even the benefit of assessment or analgesia. Examination tables are necessary because they prevent us from being too accommodating of the hospital's bed management problems to our patients' detriment. I'll move on now to designing a better schedule. Designing a better schedule will be difficult, but it can make us more efficient by matching supply, i.e. doctors, to demand, i.e. patients. This is how our supply-demand curve looks currently. You can see a couple of things pretty clearly right off the bat. Registrations per hour in blue follow a pretty smooth sigmoid curve from 7 until noon and taper off after that, while PIAs per hour, or patients being picked up, in orange, is a bit more jagged with peaks every 3 hours, corresponding to the start of each new shift. I really like this graph because the major problem with our schedule is readily apparent. You can see that from 7 a.m. until 2 p.m., we're in a deficit position. More patients are registering than we are picking up. The result of this 7 hours of deficit is that we have an accumulated debt that we don't pay off until late evening or early morning. So the patient waiting for 3 hours at 9 p.m. is actually the result of not keeping up with demand at 9 a.m. So what could we do to fix that? Well, we could move the 11 a.m. and the see and treat doctors earlier to close this gap, although that would still leave a deficit at its peak. So in order to better match the supply to the demand curve, we could just add more manpower. And we've actually done just that with the flex shift. So here are the results of that experiment. You can see that on a day-to-day comparison and on aggregate, adding another doctor helps decrease our PIA, which really only stands to reason. There are just 3 problems with adding more doctors. 1, we don't have sufficient manpower. 2, we often don't have sufficient space for them to work even if we did. And 3, it would decrease everyone's salary. So increasing manpower is a good idea, but it has its drawbacks. So perhaps we could just tweak the schedule a bit to make us all more efficient. Well, here's a graph of the average productivity of each shift, with hour 0 being the hour before the shift on up to hour 10. You can see that the see and treat shift is the most productive shift, and that every shift is the most productive at the start. I want to point out a couple more subtle trends. First, the 5 a.m. and the 8 a.m. shifts are not as productive as the other shifts at the start of the shift, perhaps because sometimes there are no patients to see. Second, the 8 a.m. and the 11 a.m. shifts lose their productivity toward the end, while the 5 a.m. and the 2 p.m. shifts are highly productive, reflecting the fact that they end in the blue zone. Thirdly, the 8 p.m. shift is very weak in the last hour, averaging only one patient picked up, again perhaps indicating that there are often no patients to be seen. These trends may indicate that the 5 a.m. and the 8 a.m. shifts should be later, the 8 p.m. shift should be earlier, and all shifts should end in blue zone in order to maintain productivity. But keep in mind that these are average trends for an average day. And the point I want to make with this slide is that there really is no average day. The chart on the left represents the day-to-day variability that we experience. So over the period that I looked at, the minimum number of visits on a Monday was 192, while the maximum was 234. The difference on Fridays was even more notable, with one very easy day at 169 and one really tough day at 229. That's a difference of 60 patients, or 26% of the total volume. And if you think of that in terms of doctors, when we see 20 to 30 patients per shift, that's an additional 2 to 3 doctors that we need. So if you look at those 2 Fridays, on February the 20th and May the 1st in detail, you can also see that there's a fair bit of hour-to-hour variability. At one point, we registered 10 patients, and then 2 hours later, we registered 20. The point here, again, is that you can't design one perfect schedule for all days, or even one perfect schedule for each day of the week. You really need to have a responsive schedule. That is, one that has a significant on-call component. And if your day-to-day variability is 20 to 25%, then you need to have 20 to 25% of your schedule be flexible. So this is a schedule that I designed when we struck up the schedule committee. You can see that most every shift begins with a 2-hour call-in period, where the doc will be called in if it's busy, and can stay home if it isn't, so it's flexible. Also, in our busy period from 9 to 12, you can potentially have 5 different doctors starting, so it's timely. Lastly, every shift ends in blue, so you can increase the productivity of each shift. But if you're going to have all these shifts that start with a call-in period, you need to have as much warning time as possible as to when the next wave is going to hit. To that end, I've created this mock-up of a triage board that I've shown to many of you. Currently, the indication for the flex shift to come in, I think, is whenever the flex doctor feels it's a good idea to come in, or when it's convenient, or if he is called, then it's because the department is in over its head already. Well, that's too late because you've already fallen behind the curve. So we need to have as much warning time as possible, and that means knowing what's happening out in triage, which up to this point is information that has been unavailable to us. This triage whiteboard would fix that. So matching doctor schedules to patient volumes is one way to improve performance, but there are many efficiencies to be gained directly from the doctors themselves. I'm going to discuss 5. One way is to decrease the doctor's decision time. You can see from this graph that our faster doctors make disposition decisions much more quickly than our slower doctors. One of the things that Rob and I are going to be working on is a set of clinical pathways to ease decision making. We're thinking of pathways for chest pain, PE, heart failure, COPD, and others. Another way is to focus our activities on work that is meaningful to our patients and suitable to our high degree of specialization as medical professionals, rather than simple administrative duties. As you can see from this time motion study graph, we spend a lot of time on the computer or on the phone, in blue and orange, in comparison with direct patient care, in gray. This was the thinking behind the physician navigator role that I created. As you can see, for most shifts and overall, PNs have helped to improve my performance. The average overall difference is 0.4 patients per hour, and this is achieved simply by eliminating some of the extraneous administrative tasks that are necessary but aren't important to patient care, or that don't require a highly specialized medical professional to do, like logging into a computer or putting a patient in a room. As you know, I've been trying to extend this program to all the doctors in our department, but the administration hasn't been willing to share responsibility for this program. Perhaps, as a group, we can come up with some sort of arrangement. Learners, too, tend to improve efficiency, at least on my own personal data, as does our NP, Laura Hill. Adding nurse practitioners would be costly to the hospital, but soliciting more elective residents might be one way to improve efficiency without adding costs. Other methods that have been employed at other hospitals include enforced minima, for example, seeing a minimum of 20 patients before being allowed to end a shift, and an altered pay scale. Money is a motivator for most, and doctors at fee-for-service hospitals tend to be pretty fast. As an example of a solution under an AFA, though, the Queensway Carleton Hospital in Ottawa, where I did a locum, pays a smaller salary than we do, but pays 70% of the fee-for-service billings. Lastly, we have discussed altering the bonus formula to give a bigger reward to faster doctors. And all of these solutions might motivate doctors to see patients more quickly. The penultimate proposal I'm going to make is a simple one. We could see more patients if they were simpler cases. Adopting this proposal really requires us to adopt a business mindset. I'd argue that we are a business and patients are our clientele. While our business has a monopoly on CTAS 1 and 2 patients as a regional trauma center, we face stiff competition for CTAS 4 and 5 patients from walk-in clinics. In fact, CTAS 5 patients represent only 4% of our patient population, and yet these patients take the least time to be seen and to be discharged from the hospital, so they would improve our numbers overall if we had more of them. I think we are being unfairly compared to other hospitals that don't have as skewed a distribution of patients as we do. So I think we should level the playing field a bit by attracting simpler cases to the ER. One way to do this would be to decrease waiting times consistently, and once it becomes known that our waiting times are much improved, people who have a choice on where to go, that is CTAS 4 and 5 patients, will choose to come here. Another way to attract simpler cases is to appeal to particular groups of patients, and I'm going to give an example here. The example that I'm going to give is suture removal. Between January 1st and May the 5th, we saw 482 patients for lacerations, but only saw 27 patients for suture removal. Let's say half of those patients actually got sutures that needed removal. That still leaves 204 patients who went elsewhere for their care. Again, using the vernacular of business, our return customer rate was pretty poor. So here's what I would propose to get these customers back. On the initial visit, the patient gets a ticket for a scheduled appointment. They also have their follow-up chart pre-printed and stored in blue. They're told that if they arrive early in the morning, when our volumes are very low, they will be seen within 15 minutes. This entices them to come back. We achieve this guarantee by having them bypass registration and triage and coming directly into Blue Zone. They could go to the registration, and the registration clerk could put them in the system, but a lengthy set of demographic questions and vital signs are not necessary. They're unlikely to have moved within the past week, and their CTAS score will be 5. Even that, though, isn't necessary because registration and triage could happen after the fact. The doctor sees the patient using the pre-printed chart to document it on. It takes 15, 30, maybe 60 seconds. And the patient has his sutures out and goes home happy. Again, we have to guarantee that they be seen and out in 15 minutes. So if the doctor is delayed by a trauma or something else like that, then we have a directive that the nurse can take the sutures out and the patient can go home. This is just one example for one patient population, but there are surely many others that we could create to attract back some similar cases to the ER. Up to this point, I've talked about ways we can decrease our average PIA, but this is different from our 90th percentile PIA, which is what we're actually measured on. I'm going to talk a little bit about how that alters our strategy. You can see that most of the patients we see have been waiting less than 100 minutes. But because this distribution is skewed, the average PIA and the 90th percentile PIA are dramatically different. While increasing our efficiency should affect both these values, if we still have outliers that are waiting a long time, we still won't be meeting the benchmark set by the ministry. So if we see 200 patients in a day and 179 of them wait 30 minutes only, but 21 of them wait 3 hours, then our PIA 90 will still be 3 hours. This difference should have us looking at the patients who wait the longest in order to decrease these outliers. So what chief complaints lead to patients waiting a long time? This table shows the top 10 reasons for visiting that end up waiting the longest to be seen at a rate more than what you'd guess by the proportion of the total visits. You can see that a lot of them are for psychiatric reasons, a total of 4 of 10, and a lot are for the less rewarding diagnoses of emergency medicine, like general weakness or generally unwell. I wonder if crisis contributes to this by taking the patient away to see them elsewhere in the department for long periods of time. I've also heard that some doctors insist that crisis see these patients before they will do so themselves, and we all know that crisis can be hours behind. With regards to the non-psychiatric patient complaints in this list, I think it demonstrates that there's probably some patient type avoidance when picking up patients from the whiteboard. I'd argue that both these behaviors, avoiding crisis patients until crisis has seen them and avoiding the undesirable cases entirely, should be curbed. I mean, yeah, these aren't the most rewarding areas of emergency medicine, but these people are patients too, and they deserve to be seen in a timely fashion. How can we change this behavior? Well, that's another question. Next, I want to look at what CTAS scores do to a patient's waiting time. If the CTAS score were objective and we saw patients in order of their score, then the CTAS 5 patients would end up being the last patients we saw, and so they'd be overrepresented in the long PIAs group. But actually, they end up waiting less often than you'd guess by random chance alone. So too do CTAS 1 patients appropriately, but somehow some of them still end up being in the longest 10% of waits. The impression that I get from spending an afternoon in triage as an observer is that CTAS is a totally arbitrary number, especially in the mid-range levels of 2 to 4. An actual conversation that I witnessed went as follows. So, how would you rate your pain? Oh, I don't have any pain. Really? You must have some pain. No, it's not really a pain. Well, you must have some pain. Let's just give him 9 out of 10. And then the computer calculated the CTAS score. Well, it's giving him a CTAS of 2, but he's really not a 2, so let's bring him down to a 3. Currently, our whiteboard sorts patients based on CTAS and then by waiting time, and we pick up patients in this order. But really, if CTAS is so arbitrary, I would recommend that it should sort patients by waiting time alone. Nurses can override this system, as they often do, by coming to get us if they think they have a patient who is particularly in need of attention. Even if we think there is some value in differentiating CTAS 2 to 4 patients, I'd still argue that we should focus more than we do right now on the waiting times. That is, we should pick up the CTAS 4 patient who has been waiting 2 hours as opposed to the CTAS 3 patient who has been waiting 50 minutes. This would trim the outliers that skew our PIA 90. The obvious exception is CTAS 1 patients. Usually, their score is pretty cut and dry. But it's never the whiteboard that tells us when we should be seeing these patients. It's the nurses who inform us of their arrival. So my suggested rule still stands. See patients in order of wait times, unless asked by the nurses. What I found when I looked at CTAS 1 time specifically was that patients were waiting unreasonably long to be seen, averaging around 30 to 40 minutes, with some outliers exceeding 100 minutes or more. This obviously wasn't the case, but was simply because the patient wasn't on the whiteboard for the doctor to sign up. The doctor would sign up for the patient after he had finished treating the patient, but even then sometimes he wouldn't remember, and I think that explains the really long wait times of over 100 minutes. The new strategy that we've come up with is to have the clerk sign up the doctor immediately when they register the patient, and essentially this makes the PIA 0. Another group of patients with an easy solution is direct consultations. Even though they are under non-emerge physicians, these patients count towards our PIA, and some of them wait unreasonably long. I'd argue that we should see these patients as soon as they come in the department. Here's my reasoning. Firstly, it's our department. We are responsible for everyone in it. You can imagine that if a patient who had been waiting 362 minutes had died or even just had a really bad outcome, every doctor who was in the ED that day would be dragged into court and asked a very simple question. So, Dr. Lenny, this patient was in your department for 6 hours. Why didn't you see him? Secondly, in my experience, direct consultation, in quotes, can sometimes be a misnomer. Several times I've found that there was a misunderstanding at triage, and someone who is just sent in to see an ER doc from a walk-in clinic or something like that waits for hours before someone clues into the fact that they aren't actually waiting for anyone else but us. Thirdly, it's an easy visit. You just get a sense of why they're here, whom they're supposed to see, and whether or not they need any quick interventions. At that point, you just phone the consultant. It's an easy way to pad your numbers a bit. Fourthly, it builds good rapport with the consultants. Hey, Dr. Jocko, your patient from Elliott Lake is here. I've seen her and she's doing okay. She's in room 18. It lets them know that we're looking out for their patients. Fifthly, for those patients that would have waited around those 362 minutes, a phone call from us might induce the specialist to come a bit earlier. Maybe they never got the message that the patient arrived. Maybe they did, but they thought the patient could just sit in the ER for a bit and it wouldn't matter. Our phone call would let them know that it does matter. So I proposed 5 strategies to improve our performance, but you could raise the objection that this focus on increased speed might come at a cost to quality of care. But looking at the percent of cases that bounce back within 3 days versus the speed of the doctor who originally saw them, this isn't borne out. In fact, there's little to no correlation at all. In terms of bounce backs, at least, faster doctors do not fare worse than slower doctors. And incidentally, we are all lower than the 8% bounce back average found in a recent study in the US. Now, that is just one metric of quality, and there are many others that we could measure. Counting the number of complaints against us would be an easy one. Slightly more difficult would be getting colleagues' perceptions of us, although they do this at South Lake. They frequently do 360 evaluations on each other. Others might involve surveying patients, a review of charts for test utilization, and accuracy of diagnoses, although obviously these are a bit more onerous. The second objection that you might raise is that all of these changes might result in little to no impact on our PIA times, but I don't think that will be the case. When I was on the schedule committee, I created a program to predict wait times based on the number of doctors who were working, the average speed of the doctors, and the number of patients who were registering per hour. The model predicted the following daily wait times based on these 3 pieces of information, which roughly models how we would perform. Increasing the average speed of the doctors by 0.4 patients per hour, or the equivalent of giving every doctor a physician navigator, would have the following impact on wait times. And that is just one change out of the many I've suggested. This is a model only, and it doesn't account for many variables such as triage speed, registration speed, or bed blocking, but I think it demonstrates that PIA can be improved dramatically with subtle improvements in our efficiency. I've covered a lot of ground in this talk, so I'm going to do a short summary here. First of all, with regards to inpatients, we have a position that is reasonable, fair, and moral, and I think we should repeat this position frequently to the administration whilst seeking support from other groups. While we wait for the administration's response, we should do what we can to reclaim our workspace by moving stretchers out and moving examination tables in. As for our schedule, we should redesign it so that our supply of doctors matches the demands of patients. Variability in patient volumes on a day-to-day and an hour-to-hour basis requires a call-in schedule, but will need as much warning as possible, which we can get through the whiteboard. There are many ways to increase a doctor's intrinsic speed, and these include decision aids, administrative aids, learners, and financial motivators. I think we should explore all of these options. As a group, we should adopt a business mindset and attract reliably easy cases. I've given the example of suture removal, but there are surely many others that we can come up with. While improving our efficiency, we should ensure that we do not impair our quality of service. There are many ways to measure this, and I've listed a few here. So that's the end of my first presentation. I thank you all very much for listening all the way through to the end. I put a lot of work into it, and I put forth the best supporting evidence I could come up with for all my suggestions. It covered a lot of ground, more than I thought it would initially. I have an even more ambitious suggestion, but given the length of this talk already, and the broad scope of this new plan I want to talk about, I think it deserves its own presentation, which will be coming up soon. Thanks.